start with a thank you for inviting me to speak with you today in this beautiful campus, and to Professors Gregorio, who brought me here, Professor Samaggio, Moro. It's delightful to be here and to speak about these very important matters. I'm going to try to keep things somewhat informal, since this, I understand, is all students in the room. So if you need me to clarify something, just raise your hand. Don't be shy. There we go. Okay, I've been studying these subjects for pretty much my entire academic career. And usually what I do in talks about nonprofits, for-profits, and government healthcare providers is to focus on the differences. But we're in this moment in the United States right now where the importance of the interactions is very, very clear. The different kinds of healthcare organizations do not operate completely separately. What the government does matters a great deal to the nonprofit sector. What the for-profits do matters a great deal to the government. And so, are there any Americans here? It's quite a time. So I will talk a little bit about what's going on, but essentially we're in the middle of, or the end of the beginning, I think, of a massive reordering of our system of government in terms of the structure of our institutions and democracy itself. And so what this means for nonprofit healthcare, yet to be seen, but I have some ideas about it. What we're seeing, though, is that it's hard to think about the institutions in isolation, as I said, and it's even hard to think about the institutions in terms in just national terms. So today, President Trump announced he's going to put tariffs on pharmaceuticals, right? This has, huge international consequences, but huge consequences for the provision of healthcare and for spending in the United States. I'm not going to go through this in detail. This is just to say to those of you who are not American, it's impossible to understand our system, right? We don't have a system. What we have is a collection of very different systems. So we have providers of care, both at the federal level and the state level, but also in municipalities and counties. Our insurance system depends on your age, your socioeconomic status, whether you're employed, a bunch of different factors. So there's really no such thing as a system. And we have a complete mix of sources of spending in the United States. So this is the most recent year for which we have data, but in 2023, we spent almost $4.9 trillion on healthcare. The United States obviously has a massive economy, but this accounts for about 17.6% of GDP. So there's no country in the world that spends anything like what we spend on healthcare. And we spend a lot of that money, say about 5% of GDP just through hospitals alone. And as you'll see, the majority of those hospitals are nonprofit hospitals. But the reason for putting this chart up is not just to say, wow, is this a very big part of our economy? But we tend to think about the United States as having a private healthcare system, a for-profit healthcare system, and one that's built on private sector capitalism. It's a very odd kind of private sector for-profit capitalism when almost 50% of spending comes from public sources. So this is one of the reasons I say that it is true that we have entirely nonprofit and for-profit providers of care through hospitals, through insurers, private doctors, right? There's no such thing as a public doctor. Some of them work for public systems, but they're all private business people in some respects. But our spending really, in large part, depends on government spending. So it seems to be impossible to think about a healthcare system when you're providing sophisticated modern medicine to be one that can be provided through a private for-profit system. We just can't afford anything like that. We need tax dollars to support this. I made the point earlier that where you get your insurance, where you get your health care very much depends on things like your employment status. So if I were to ask one of the Americans here about where if I had to guess where their families got their insurance, I would have to ask a lot of questions first. I'd ask if their parents are employed. Are they veterans? Are they rich? Right? How old are they? And then I could make guesses about where they get their insurance for care and where they're able to get their care. So very different than in other countries where there's something like universal insurance. In the past, we've not done such a terrific job, and we're still not doing a terrific job about giving everyone access to care. So before the Affordable Care Act, which we call Obamacare, about 19% of adults in the United States under age 65, at which point you get on federal insurance, were uninsured. They didn't have access to insurance. We've done a lot better after the Affordable Care Act was implemented. We're down only to about 9.5% uninsured, but this really undercounts the number of people who are uninsured because these are people who are permanently uninsured in a year. If you look at spells of uninsurance, do I lose my insurance for a period of time in between employment, for example, you find a much higher number. About 25% of adults in the United States are uninsured for some period of time in any 2-year period. Doesn't mean that they don't get health care. Right? Our emergency rooms treat a lot of people. It's a terribly inefficient way to get care to people, but they have to take all comers. Everybody who is sick and goes to an emergency room gets some care. Not necessarily great care, but their emergencies need to be stabilized. So we have some kind of health care available to everybody, often through nonprofit institutions, but it's not a very logical way to operate a healthcare system. And so now we're even seeing economists start arguing for national health insurance. That is very unlikely to happen over the next few years. I want to make one point about the alternatives. So the Democrats in the United States, the Democratic Party, likes to look north to Canada and say, that's what we need. We need to do what Canada does. We need to have this fully government system. But that's kind of a misnomer about even a country like Canada. Everybody has basic health insurance in Canada. There's a fair degree of equality in treatment of medical problems in Canada. But there's a large part of that system that is also private, nonprofit, and for-profit. So about 2/3 of Canadians have some form of private insurance in addition to the public system. So it's hard to think about these systems as being fully governmental or fully for-profit. In the US, we think about ourselves as for-profit, but we're really not. Right? The government funds about 50%. In Canada, they think of themselves as having a public system, but they're really not. There are lots of other kinds of for-profit or nonprofit insurance plans that most people also have. So these aren't pure systems. Okay, I'm going to dig down for a little bit and talk about what it means to be a nonprofit and how nonprofits differ from for-profits, and to a lesser extent, talk about how they differ from government entities. And I'm going to focus on the hospital industry because that's kind of the clearest example. That's where I've done most of my research. I'm going to put some numbers up. So are there any economics students in the room? No. Okay, I won't scare you with numbers. It should all be intuitive. But we call them trigger warnings at home. The graphs are coming. Okay. So what this shows you is this is for urban hospitals. So it's about half the hospitals in the United States. The charts for rural hospitals look similar enough. The vast majority of hospitals in the United States are private, but they're nonprofit. So they're privately owned, but you can think of them as being owned by their legal purpose. They're not owned by shareholders. They're not owned by private people. They're owned by the purpose of providing healthcare, and they're governed by boards of directors or trustees who have a responsibility to make sure that quality healthcare is provided in these institutions. The differences between the two lines up at the top there, do we have, no, I don't have a pointer. Nonprofits tend to be bigger than other hospitals in the United States. And so when you adjust for admissions, it's an even bigger share, right? Because more people get their care in nonprofits than just the number of hospitals would suggest. This has been remarkably constant over time. So even though we have a lot of activity in terms of selling and buying hospitals in the United States, on average, those are pretty flat lines. I could have gone back actually even several decades before and shown you that the mix between nonprofit, for-profit, and government hospitals stayed more or less the same. So what's the difference? Let me say one word first about what's a nonprofit. Differs slightly in different countries, but we have generally the common law. We've imported the common law from England, despite the fact that we were running away from them. We thought a lot of their law was very good, and we wanted to take it with us. And so the purpose of providing healthcare is a charitable nonprofit purpose under the law of most states. And so when an entity incorporates as a nonprofit hospital, they get to be a nonprofit corporation. With that status comes a lot of special treatment. And so under federal law and under state law, these hospitals get tax exemption from income taxes, from property taxes. They have the ability to issue tax exempt debt, bonds. So if they want to buy new machines, for example, or start a new medical service, that's a very expensive thing to do. And if you're a for-profit doing that, you go to the markets and you issue more stock and you get money to build your company, right? You can't do that if you're a nonprofit. And so they issue, essentially take loans through the form of bonds. Lots and lots of deductions, and there's a huge range of estimates about what that's worth to the sector. So some people say every year the federal government loses $40 billion in tax exemptions. Other people say it's as low as $13 billion, but pretty big numbers. There's a controversy going on right now that people suggest that nonprofit hospitals don't do enough good. We have all these uninsured people. I've just explained to you why our healthcare system is, I don't have a polite word for it, a mess. You know, it's in trouble, right? And the nonprofit hospitals ought to be picking up the slack. They ought to be giving people free care. I disagree with that for reasons that I'll talk about once I've talked a little bit more about my research. But essentially, what I want to say, in the United States, we have a bunch of expressions about money not growing on trees. So I bet lots of people have that expression in your own languages, in other countries too, something similar. So when my children ask me for money, I tell them there is no money tree. There isn't one growing in the basement. It has to come from somewhere, right? this is essentially the story for nonprofit hospitals. If the federal government, Congress members want a nonprofit hospital to pay for the free care for all those people I showed you that don't have insurance, the money has to come from somewhere. And it has to come from the insurance that other people pay. And it just doesn't exist, because when I go to the hospital and my private insurer pays because I have a broken arm or I need surgery, they don't pay for me and for 3 other people who need it. They just pay for me. And so it's unclear where this money is supposed to come from. There's an interesting historical note to make about this. People sometimes think that nonprofits have lost their way, that they used to give all this free care and they no longer do. But this is just historically inaccurate, right? Nonprofit hospitals have always charged for care. They've just done so in different ways. So sometimes they've charged money when people could pay, but sometimes they charged in the sense that patients who went to the hospital, say in the late 19th century, were used for practice by the doctors who were learning to do surgery, right? That's a form of payment. If you bring your body for a doctor to practice on, you're giving something of yourself in exchange for the care, right? The risk of dying. If you were admitted to an early American hospital, sometimes the boards of directors would choose who to admit. And so they'd say, are you a good sewer? Can you look after the other patients in the hospital? And then they would make you perform labor in exchange for coming for treatment in the hospital. So there's always been some form of payment for a very long time. So I'm going to take a turn here and talk a little bit about my research in this area. So what I've done over several years is decided not to look at whether nonprofit hospitals pay for free care, essentially act as insurance companies, but what they do that's different from other kinds of hospitals in terms of providing medical services. So I took every medical service that a hospital offers. So things like open heart surgery or orthopedics, psychiatric care. There's a long list, but 30 or 40 services. And then I split them all into services that were either pretty profitable, relatively profitable. If you wanted to make money, you would offer this service. Or services that were unprofitable. If you wanted to make money, you would not offer this service. And then I looked at services for which the profitability changed. And I took a look at how the for-profits and the nonprofits and the government hospitals differed in terms of the probability that they would offer that service. So here's the first example. This is for cardiac care. So cardiology, this happens to be for open heart surgery, but the graphs look pretty much the same for other kinds of invasive cardiac care. So putting a stent in your heart to open up your arteries, or doing catheterization to look to see whether you have a blockage. All of these are very profitable services for hospitals. And what you see is comparing nonprofit, for-profit, government hospitals, importantly of the same type, right? I've just told you nonprofits are bigger, so they are more likely to have more of everything. So you have to compare same. So hospitals, these are the results of doing that exercise. Hospitals that are roughly the same size, employ the same number of people, operate in the same kinds of markets. So people with this similar levels, adjusting for levels of education, for income, for training of doctors, whether the hospital is a teaching hospital affiliated with a university. So making all of those adjustments, what you find is the very fact of being a for-profit hospital means that you are much more likely to offer this profitable service. Then if you're a nonprofit, they fall kind of in the middle. And the government hospitals are the least likely. So this should be shocking, right? Because we're not talking about whether you're offering, whether you're a car dealer and you decide that you're going to focus on offering Ferraris versus Hondas, right? We're talking about basic medical care for people who come to the hospital. And whether you're incorporated in a certain kind of way determines whether you offer these very profitable services. So here's an example of a very unprofitable service, psychiatric emergency care. So why is this unprofitable? People who have psychiatric emergencies and go to the general hospital, well, they tend to be poorly insured, and have lots of comorbidities. So once somebody goes to the emergency room with a psychiatric emergency, well, then they're in the hospital for a very long time with very complicated problems, and nobody is paying the hospital adequately for providing those services. So if you want to avoid poorly paying patients, you would not offer this service. And so we see just the opposite relationship here, right? The government hospitals are now on top, right? They are most likely to offer the service. The nonprofits, again, in the middle, and the for-profits, well, they're just avoiding the service altogether, right? So here's an example that kind of cements the story. It tells me I'm onto something here. So what this is a picture for a service, home health, whether you can get care, but whether the hospital arranges care after the fact in your home once you're discharged from the hospital. But these look pretty much the same for skilled nursing facilities, which are part of the hospital. So what happened here is prior to 1996, there was a period where it became very profitable to offer these services for a bunch of complicated reasons, but more or less, if you were a hospital offering home health, you could get 2 billings per patient. You could get a billing for the treatment in the hospital, and you could get a separate reimbursement for the billing out of the hospital. It wasn't bundled. And then somewhere in here, as you're going up that curve to the top, there was a court case that said, no, you can't do that anymore. And so the for-profit hospitals dramatically got out of the business. So what this shows you is that for-profit hospitals, because they're for-profits, they're incentivized by earning money more than the other kinds of hospitals. Here's a more recent example of this. So even for a service as basic as emergency rooms, there had been a difference in whether hospitals were likely to have an emergency room, with the for-profits least likely to have them because they were quite unprofitable. In recent years, it became a little easier to make money on an emergency room because hospitals figured out various techniques to do that. They would have satellite emergency rooms, and they wouldn't be so much at risk of having to admit an unprofitable patient. And so hospitals figured this out, and that's exactly when the for-profits that did not have emergency rooms started providing emergency care. So they're quite responsive to financial incentives. So one response to this that you might think is, wow, this is just not surprising at all, right? If you're a for-profit company and somebody holds a dollar bill in front of you, right, the for-profit responds. That's the point, right? And if you're a nonprofit, you're less likely to do that. You don't have the same incentive, right? But it's surprising in this context, because in this context, these hospitals all have people who are trained the same way. They all have patients who need a vast array of services. It's a highly, highly regulated industry. And so you wouldn't think for something as basic as whether you offer certain kinds of surgery or whether you have an emergency room would show this much responsiveness. So you might think this is a good thing, right? If we have a reimbursement system that says, we're going to pay you this much for heart surgery because we want you to do this much heart surgery, well, then great, we're giving you an incentive, right? If you're in the United States and you go to an Italian ice cream store where they sell gelato, it is more expensive than going to a basic ice cream store in the United States. And that is because the Italian ice cream is better, right? And so we like that, right? But that is not the case here. This has nothing to do with quality. It has nothing to do with access. Right? And so we don't want this kind of responsiveness to financial incentives because we also don't think the government can get it just right. Markets for ice cream work really well, right? Typically, the more expensive the ice cream, the better it tastes, right? The fancier the furniture, the more expensive it is. But that is not how it works with open heart surgery, right? Or psychiatric emergency care. And so these signals that the market sends are not signals that we really want our providers to respond to. And in this respect, the nonprofits really do a better job. So this is why my response to the suggestion that we should take away tax exemption from nonprofits is we absolutely should not. We should stop judging them on whether they provide free care because they don't have their money tree. We should start judging them on the medical services that they provide. And if we look at them not as insurers or banks, but we look at them as medical service providers, we have a very different story. So let me see where I am here. I'm going to very briefly talk about what's going on in the for-profit sector in the United States. And then I want to open it up for discussion. I want to hear what your thoughts are about nonprofits, how they operate in your countries, what you think my students ought to know about your perspective. So one issue with for-profits and the increasing provision of for-profit medicine in the United States is what I showed you does not only affect what's happening within a hospital. So if I'm a for-profit hospital, I will open more open heart surgery. If I'm a nonprofit hospital, I'll open less. I also looked at how there are spillover effects. So if the hospital next door to you is a for-profit, regardless of whether you're a for-profit, nonprofit, or government hospital yourself, you copy what the guy next door does, right? You're more likely to behave like a for-profit if a for-profit is your neighbor. You can think about it as peer pressure. You can think about it as market competition. But the more for-profits there are, the more all the hospitals, including the government hospitals, behave like the for-profit. So this is a chart that shows you that, so the one up here on the top left shows you during the AIDS crisis, during the early 1990s, when we really needed these services, the nonprofit hospitals that had more for-profit competitors were less likely to offer AIDS treatment in their hospitals. Right? Psychiatric emergency services, same story. If your neighbor is a for-profit, well, maybe you're competing with them and you can't afford to offer that unprofitable service. Now, up until recently, for-profits were usually big publicly traded hospital chains on stock exchanges. They had for-profit motivations. They had to get returns to their investors, but they were usually in the market for the long run. Right? They wanted to survive. They wanted their hospitals to be known as high-quality hospitals. And in fact, they did some quite good things. Columbia HCA, which doesn't exist anymore in that form, but it was the 9th largest employer in America, this hospital chain. And it specialized in buying kind of the worst hospitals in the country, what they called the dogs. So what we thought they were doing is maybe not making the best hospitals, but they were at least standardizing the hospitals. So here's a very American explanation of this. One of my colleagues once said, well, if you're driving on the interstate highway in the United States and you want a hamburger, right? You could go to a local hamburger place in some town, and that hamburger might be really, really good, or it might be really bad. It's just hard to tell before you eat that hamburger. Well, if you go to McDonald's, it might not be the best hamburger, but you know exactly what you're getting because a McDonald's is a McDonald's is a McDonald's. You've got a guaranteed level of quality. It's not going to be the worst of the mom and pop local hamburger place. And that is kind of what this company did. It turned all the bad hospitals into McDonald's. Not great, but safe to eat. Right? It's really different now. In the past 15 years, investments in for-profit hospitals have been increasingly made by private equity firms, and they have a very different model. They invest a lot of money quickly. They sell off the pieces in terms of the real estate, the management of the hospital to various kinds of for-profit entities so that what's left is a hospital that really doesn't have any inherent value. It's just a collection of contracts, really a collection of debts. And so this has been happening all across the country. It's been happening with physician practices, with hospitals. And it's led to a lot of market power. They've gotten so big that prices have gone up. And sadly, quality has gone down. Right, so what this shows you is one example. These hospitals, once they get acquired by private equity, it's more likely that you would get a complication, some kind of infection in the hospital that it was before they were acquired. That's what this chart shows you. That line is the year that you were acquired by private equity, and then you see the probability of getting an infection, something bad in the hospital, like MRSA, that goes up. This one is, I find particularly upsetting. Patients who were in private equity-owned hospitals with COVID were more likely to die. So this is what I just said. The profits in these places are taken out of the system. So in nonprofit hospitals, the profits exist. You're allowed to make a profit, but they have to be reinvested into the hospital. They can't go to private parties. In a for-profit system, they can go to shareholders, but again, usually people held that stock for the long haul, right? That those hospitals were meant to stick around. In private equity, they move quickly. You know, in 2 years, they take the money out, they sell to someone else. And we've seen massive bankruptcies. This is an infamous case that's going on right now. Steward Healthcare was the largest private equity-based owner of chain hospitals, a big chain of hospitals in the United States, and they've gone bankrupt, and the hospitals are closing. There's mass layoffs. And there are no buyers for these hospitals because, as I said, they don't own their land, they don't own their buildings. All they are a collection of debts. And so it's unclear what exactly is left once the private equity firm is done. So this is a bit of a cautionary tale about the attraction of quick money coming into the healthcare system. So where do we go from here? Sadly, I think things are getting worse, because we're seeing a lot of people laid off in the United States. I don't know if you've been watching the stock market over the past few days. You know, we have had a massive reduction in wealth in the country. We're going to see rising unemployment, and we see efforts to reduce federal spending, particularly in Medicaid, by the tune of almost $1 billion over the next few years, which means that people who don't have insurance are going to have even less access to care. So more demand on the nonprofit hospitals. I could be, I don't want to depress my American friends here, so I might not go further. But we're in a pretty rough situation. And in part, our investments in the for-profits are making us more vulnerable than we would have been if we just kept, if we could have had a mix of just nonprofits and government hospitals. So with that, I will, I want to hear your experiences and if you have any questions. So if you don't have questions, I'm going to call on you. I can hear you.
Sorry. Okay, I'm gonna say it again. So in Italy, we have a peculiar situation right now because well, health is public, but because of the high demand and the less and less investment from the government in health, there is this thing where they say that because the waiting list is so long, you can go private and you'll be reimbursed. But I think I find this direction to be possibly problematic, especially for the future, because first of all, the reimbursements are not quick at all. And also, what about the people that can't afford to spend, spend in advance that money and maybe hope that someday they will get reimbursed, both because the private sector is very expensive and the waiting lists of the public health are crazy, like they go from 5 months onwards. So it's not, I mean, it could be a matter of life and death. So I don't know, do you have any opinion or observation? Thank you.
A lot of countries have this problem. I have mixed feelings about whether there should be a private buyout at all. I mean, in some ways, allowing a little bit of a private buyout allows for some of the pressure to come out of the system. So if you have 5%, for example, but there's some risks to that. So what we're seeing in wealthy cities in the United States is increasing what we call concierge medicine, where people will pay doctors a fee to promise to only take so many patients a year. And those fees range anywhere from, I heard the other day, $6,000 per person in Los Angeles, where someone I know, every person in their family spent $6,000 extra to have a doctor kind of on call for their, not just for their family, but for a panel of patients, right? That takes that doctor out of the system. And that is, highly inequitable. But maybe a little bit of that allows, in a place like the United States, a release from some political pressure. On the other hand, we're not doing things fast enough that we need to do. We have an aging population, so demand for healthcare is only going to go up. We have an aging population, so there are fewer people who are going to become doctors. And so we're heading towards a crisis, and then closing our borders to people who come in and serve them is, lunacy. So we're going to see that problem even worse. And there are some solutions to that. So the way Canada deals with that, and Canada has a major problem along these lines with waiting, is they have made the choice that it's hard to get in at the beginning, but once you're diagnosed with something serious, you're treated actually pretty well. There's a lot of coordination, and the quality of care is actually quite high. In the United States, we do that kind of rationing, but we tend to do it by wealth. And that seems particularly troubling. One thing we could do, and we've done a little bit at the state level, is we've loosened up licensing. Canada's done this a little bit. So you could say, okay, this service that only a doctor can provide, we're going to let a nurse provide it, or a physician's assistant provide it. Or as they do in Canada, again, Canada has lots of problems. So I don't want to just say Canada is the answer. In fact, my colleagues in Canada always say they only have the second worst healthcare system in the world. So they have a lot of the same problems we have in the States, but they let their pharmacists prescribe basic drugs. You know, why should you have to get a doctor's prescription, as we do in the United States, to get something for your foot fungus, right? A pharmacist is perfectly capable of prescribing that, and then you're not taking up time with the doctor. But we seem to like our doctors to do things. So I'd give you one more example. I'm a very terrible patient. So I was impatient with a chest cold that wouldn't go away. I went to the doctor, and this doctor wanted two things. One, he was an internist at a major teaching hospital, and he was seeing me. And so after he examined me, I said, "Aren't you embarrassed? What are you doing? Don't you have real patients to treat? I should be seeing a nurse for this. There's no reason that someone with your training at a major international medical center should be seeing someone like me." Right? So that shows you the waste. And furthermore, he illustrated the kinds of things that are wasteful. So somewhere between 30 and 50% of healthcare is just a waste. Problem is, it's hard to figure out what's wasteful. But this is an anecdote, but it's a nice anecdote of how medical care gets wasted. So then he prescribes an antibiotic for me, and maybe I should have had it, maybe I shouldn't have, I don't know, but it made me happy because it gave me something to do. I thought I was acting. And then he wanted me to do a chest x-ray. And so I said, well, what would you do differently depending on that chest x-ray? And he said, nothing. Right? So two problems: it's expensive, and he's exposing me to radiation. And we know that we have a lot of unnecessary scans in the United States. It's one of the most overused services. This one would have done nothing for me. And about 2% of the cancers in the United States are caused by unnecessary scanning. Right? So that is not only wasteful medicine in terms of the wrong provider is doing the care, he's prescribing something that's expensive, and it's not going to help me at all. In fact, it could hurt me. Right? So that kind of in making care more efficient would go a long way to solving some of the problems. And for that, it's almost the opposite of being able to buy out, because we want people who want to buy out of the system and get private care want to be treated for what's bothering them. So if you just have a paraprofessional saying, you know what, I've seen this a million times and what you have is fine. If it doesn't go away in X number of days, call me back, right? And then you calm down. When I had my first child, the hospital gave me a phone number to call for people like that, like people like me. So the first time the baby got hiccups and it wouldn't stop and I was terrified, I called the hotline and somebody said, remember when you were pregnant and the baby had hiccups? It's the same thing. I mean, I'm embarrassed that I did that, but you know, we worry. And so you don't need a doctor or a nurse answering the question about hiccups. That's a trivial example, but it's a good example because without that hotline number, I would have called my pediatrician. Right? So there's a long example, but there are lots of ways we can solve this problem. I also understand that physician pay is a lot of what's causing the problem. So at some point you have to invest more money in the system. But you can do that by cutting unnecessary care.
No question?
With cutting unnecessary care, I was wondering if you had any thoughts on physician-owned hospitals in the US and if those are kind of like beneficial or detrimental to the system.
You know, it depends on the,
Could you give your name and university?
Yeah, I'm Caroline. I'm from Boston College.
I'm from Boston. So there's some forms of physician-owned hospitals that, I mean, right now Medicare won't do reimbursement for new physician-owned hospitals. So we have the system where groups of physicians can own hospitals. Many of them are specialty hospitals, and they're the most profitable services. So the physician-owned hospitals tend to be hospitals that only do cardiac care or orthopedic care. And I think they're very damaging to the system, in part because they often treat patients who maybe don't need to be treated at all. They treat the healthiest patients, and they take a profitable service out of the general hospital so that the general hospital can't make the profit on that service and cross-subsidize to the unprofitable services, which is why those nonprofit hospitals are able to offer the unprofitable services, right? They have the cardiac center, so then they use the money to provide unprofitable services that poor people tend to need. So I think that those freestanding hospitals maybe are not such a good idea for the whole system. But there's one form of them that I think we should not have thrown out, which is in very rural areas. Sometimes there've been consortium of doctors that have owned rural hospitals, and it's the only way to get the doctors to practice there.
We have a question from an online participant. So considering the damages to the service that the entrance of private equities into the system brings, are there economic justifications for this phenomenon in terms of efficiency? And then a follow-up, what do we know about the administrative costs of such a complex system? Wouldn't those costs be much lower under a single payer system, especially considering the fact that the public sector already shoulders half the cost? And that's from Giovanni Brescacin online. Thank you.
The economic justification is often efficiency, and that, you know, business people know how to run things. But I think there's a misunderstanding often of what the word efficiency means. So people tend to use the word efficient to mean low cost, but that's not what efficient means at all. Efficient means achieving your goal in the lowest cost way possible. So if your goal is to make money, the lowest cost way to achieve that goal would be not to provide any care at all and just take the money, right? That is not what we want, right? What we want to do in this system is provide high quality, easily accessible care to people who need it. All right, that's a very hard task. And so can private equity do that? Seems like not really. What private equity is good at doing is identifying money-making opportunities. So without a lot of oversight and a lot of regulation, it's hard to harness that energy. Now, there might be some room in healthcare for private equity. So if you want to take a new invention and turn it into something marketable, they're pretty good at that, right? But running a hospital system, not so good. Would we be more efficient with a universal public system? It depends what kind, right? There's lots of different kinds of universal public systems. Some of them run quite efficiently, and they operate by requiring purchase. For example, in Germany, everybody has to purchase health insurance, but the private markets are the health insurers. It's just highly regulated. That can be a very efficient system, although they're having their troubles too, right? Healthcare is getting more expensive. It's getting better, but that also means it's more expensive, and it's eating up more of the public sector in every country, right? So a system like ours, could single payer be a lot more efficient, a lot lower overhead costs? Sure, it could be, but recall what the slides I put up at the beginning, that's only one of our many problems. There is no, as we say in the United States, there's no single bullet here. There's no one way to make the system better. So we could have a public payer system, but we would still have a disorganized and disaggregated system of different kinds of public payers, right? You know, is it the federal government? Are we getting rid of the partnership with the states through Medicaid? Is it the federal government that no longer operates veterans care? So a fully integrated federal insurance system would surely have much lower overhead than what we've got now. But then our providers would still be completely disaggregated. So we'd have to do a lot of reforms to cut administrative spending.
Any other questions? If I may ask one. Okay, so I was wondering in your presentation of the percentage of GDP spent on health, does that account include also what is spent on insurance? I mean, does it
Yes.
include the profits of the insurance sector?
Yes, although, I mean, interestingly, people think that these hospitals and insurance companies are wildly profitable. And in some respects, some of them are, but nonprofit hospitals, on average, operate at a negative operating margin in a given year. They're just not doing all that well. The for-profits make a lot more money than the nonprofits. Same thing with the insurers. There's a wide range in how much the profits are, and they're not quite as big as you think. It's a pretty in many states, it's very state dependent, but in many states, it's a pretty competitive industry. And I know it is quite popular in the United States to hate insurance companies, and they're worthy of a lot of that, that venom. On the other hand, they've done some good things. So remember, I talked about how much unnecessary care there is. There are some very nice examples of the way insurance company has stopped people from getting unnecessary care through preemptively denying insurance coverage for things that are unnecessary. Their tools are a little too blunt sometimes, and we see all kinds of examples of overuse of that, denying people care that really is necessary. But there's a lot of care that really isn't, and it costs us all quite a lot.
Thank you so much. Well, I think we can wrap it up here. As we're on an island, we're very much tied to our boat schedule. And we have a 6 p.m. boat. So thank you very much for your talk today, Professor Horwitz. It was very interesting. Thank you.